Welcome to the Radiology Vault, an open repository for radiology educational content designed for learners and medical professionals. Presented by the Michigan Medicine Department of Radiology.
Hi, I'm Swati Mody, Pediatric Radiologist at Mott Children's Hospital, University of Michigan. For today's lecture, we will focus on evaluating cystic head and neck lesions in children. We will use clinical presentation, lesion location, and imaging characteristics as tools in differentiating between various lesions to arrive at a differential diagnosis. So let us start off with a frequent encounter from the ED. A 9-month-old male with left neck mass swelling since few days with fever. So we have neck and chest x-rays over here with soft tissue mass on the left side of the neck. It is not indenting on the airway. On lateral view, we see prominence of retropharyngeal soft tissues with bowing anteriorly. Now this space should be no more than 7 millimeters at C2 level. This was concerning, so the patient went on to have CT with contrast, which shows this large soft tissue mass of lymph nodes with abscess formation, with peripheral enhancement and focal low hypodensity. We have inflammation in surrounding soft tissues. We see similar findings on CT in coronal plane. So these are consistent with suppurative lymphadenitis with abscess formation. The patient was positive for staph and strep. However, not all neck swellings are lymph nodes with abscess. So let us look at other lesions which may present acutely, similarly, or over a long duration of time. So let us start off with midline lesions. So here we have transverse ultrasound in a 6-year-old presents with neck mass. Going from above down, we have the hyoid bone over here, and we start seeing a paramedian soft tissue mass. It's hypoechoic fluid attenuation, and the thyroid gland, which is separate from. There is no flow and there is increased through transmission, so it's consistent with a cystic mass. So this patient presented after 2 years again with infection in the neck, and on further history, there was recurrent infection. So on CT with contrast on coronal plane, we see this elongated cystic lesion with peripheral enhancement and surrounding inflammatory changes. On axial view, again, we see the same findings. It is just off the midline. Now, this lesion is very closely applied to the hyoid bone and appears to extend towards the thyroid gland. So, what is our differential? Lymphatic malformations. You can throw them pretty much in any differential for cystic masses in all the spaces of the neck. Dermoid epidermoid, the lesion is near midline. Thyroglossal duct cyst, it is towards midline and closely applied to the hyoid bone. Branchial cleft cyst, it is a little paramedian, so we're throwing that in. So the diagnosis was thyroglossal duct cyst. Now, these can occur anywhere along the thyroglossal tract, which is a transient epithelial lined duct which extends from the foramen cecum at the base of the tongue towards the thyroid cartilage where the thyroid eventually forms. These are most common congenital cystic lesions in the neck. They are closely associated with the hyoid, as in our case. They may even be within the hyoid bone. The suprahyoid lesions tend to be midline. The infrahyoid lesions tend to be more paramedian. Malignancy is rare. Now, because of recurrence, we perform special procedure called a cyst trunk resection. The entire hyoid bone is removed along with the entire thyroglossal duct tract and portion of the base of the trunk to prevent recurrence. Now let's move on to another case. A 4-year-old female with swelling in the oral cavity recently noticed there's no associated pain. So these are axial CT post-contrast images. We have this elongated hypodense cystic appearing lesion and small extension posteriorly in the submandibular space. So if you look at the spaces, this is a genioglossus geniohyoid muscle and this is a mylohyoid muscle. So this resides within the sublingual space over here. And posteriorly, we have submandibular space, and so the lesion extends into the submandibular space. On coronal images, we see the same. There is a cystic lesion here in the sublingual space. Again, genioglossus muscle, sublingual space, and submandibular space. And there is a myelohyaloid sling in between the two. So what is our differential? Again, we come up with the same culprits, lymphatic malformation, ranula. If it is, what type is it? Dermoid, epidermoid, it is just off midline. Thyroglossal duct cyst, it's a little anterior for that, but it is still at the floor of the mouth. And branchial cleft cyst, it is not because it's completely the wrong location. So based on the sublingual space, we come to the differential of diving ranula. So what is a ranula? It's a retention cyst of sublingual or minor salivary glands. Now, a simple ranula is true cyst, which is epithelial line, and it is confined to the sublingual space. When it ruptures posteriorly into the submandibular space, it is called as a diving ranula, as was in our case. So we have a companion case here. This is a 12-year-old with neck swelling for a few months, which is increasing in size. So what do we have here? T2-weighted images, axial and coronal. We have this large cystic lesion over here, which is extending. This is a myelohyoid muscle, so it is within the submandibular and sublingual space. There are septations within it. On coronal images, it appears to be predominantly submandibular, but mind you, it is going across the midline, so it is in multiple spaces now. On post-contrast images, we have enhancement of the margins as well as the septae within the lesions. There is no surrounding inflammation. So we have a septated cystic transfacial mass with enhancing margins. So what is our differential? Again, we go to the same culprits: lymphatic malformation, ranula, thyroglossal duct cyst, dermoid, epidermoid, branchial cleft cyst. So it is not a ranula because it is not predominantly sublingual. It is a little off the midline and it is too high for a thyroglossal duct cyst. It's too off the midline for that. It is not a dermoid, epidermoid for the same lesion and not a branchial cleft cyst. So given the transfacial location, this is most likely a lymphatic malformation. So let's look at vascular anomalies. So we have vascular tumors such as hemangiomas, which are solid. Those are the omas. The vascular malformations, which may be fast flow malformations such as AV malformation and AV fistula, and the slow flow malformations such as the lymphatic, the venous, a combination thereof, or capillary. So our interest is in the slow flow malformations, the lymphatic and venous, which present as large cystic places. So majority of these lymphatic malformations are simple malformations. They are macrocystic, where the cyst spaces are larger than 1 centimeter, microcystic, or mixed. Now, one thing to remember is microcystic malformations may present as solid lesions on imaging because of innumerable small cysts. Imaging in lobulated cystic lesions, the larger ones, very typical. There is no flow on Doppler imaging. There may be multiple septations and fluid levels. The fluid levels are because of proteinaceous content, infection and pus, or hemorrhage. Now, MRI shows the same findings with fluid levels. They may show enhancing septae and diffusion restriction because of all these contents. Now, it is mainly used to identify the anatomic extent of the lesion. The most important thing to remember for lymphatic malformation is they do not respect tissue planes and are often times multispatial or transspatial in location. Lymphatic malformations may be complex occasionally when they may involve multiple sites or they may be associated with various syndromes. So, just for an example of one of the complex lesions, this is a 5-month-old male with left neck and shoulder extensive mass. So, on ultrasound, we are seeing more of hyperechoic areas, suggesting more solid component to it. There is also some flow on Doppler imaging. Now, on a spectral Doppler, we see a slow hum of venous flow in the lesion. There is no AV shunting over here. So is this a solid or cystic lesion? On MRI, we have this extensive transspatial lesion, which is causing some overgrowth over here. T2 hyperintense and markedly enhancing. There is a large draining vein associated with this. So now we have a transspatial lesion. So there could be either lymphatic venous malformation or neurofibromatosis. Those are the two lesions. Now, neurofibromatosis tend to be solid lesions, and this is kind of solid lesion. But the giveaway over here is a large draining vein. We have a large vein over here suggesting it's a vascular lesion. And this was a microcystic lymphatic venous malformation, PIK3CA mutation. Okay, so with that, we will move on to another set of anomalies. This is a 14-year-old female with left jaw lump since a few weeks, no pain, no redness. So we have ultrasound over here, which shows us this is a submandibular gland, and the lesion is filled with debris. There is increased enhancement throughput. Over here, this is sternocleidomastoid, and the lesion is medial to that. And it is separate from the vessels and separate from the thyroid. There is no flow within the lesion. As you can see over here, you can see the debris moving slightly, but no flow at all. So this lesion is medial to the sternomastoid. We did MRI for the patient, and we see a T1 hyperintense lesion in the same place. On T2, it is hyperintense markedly. This is a sternomastoid. It's medial to it. It is posterior to the submandibular gland and lateral to the carotid space over here. There is thick enhancement of the margins. It is unilocular lesion. So what would our differential be? The usual suspects: lymphatic malformation, branchial cleft cyst. If that is so, what type is it? Thyroglossal duct cyst. Well, it is conceivable, but it is too lateral because this is at the level of hyoid. So it is too lateral for that. Could it be a cystic neoplasm or an abscess? Well, there is no inflammation around it for it to be an abscess. It's a branchial cleft cyst type 2. So talking briefly about the branchial anomalies, the review of anatomy of branchial apparatus is beyond the scope of today's session. So what we have here is a bunch of branchial arch anomalies. They present as cysts, fistula, sinuses, or cartilaginous remnants. They could be bilateral in 2 to 3% of cases. They can be often familial, and they may present as recurrent infection and abscess. The important thing is they may have fistulous tracts. So it is important to have complete excision of the tract also to prevent recurrence. Now, on imaging, they all have well circumscribed margin, thin wall cystic areas, no septation. The walls may have some thickening, and there may be some perilesional edema if there's inflammation. And we have to look out for a fistulous tract. That is important. So this is our second branchial cleft cyst case which we saw. They are the most common of the branchial cleft cysts, 95%. They tend to occur, as in this case, anterior and medial to the sternomastoid, posterior to the submandibular gland, and lateral to the carotid cyst. Now, if there is a fistula, it is along the anterior margin of the sternomastoid in the lower third of the neck. The second most common variety of branchial cleft cysts is the first branchial cleft cyst, about 4% of the branchial anomalies. They tend to be periauricular in and around the external auditory canal, or the parotid space, or at the angle of the mouth. The important thing is if they have a sinus tract, which we can see, then it goes to the external auditory canal. Now, the differential, which is peculiar for this lesion, also includes the parotid lesions, such as abscesses or siloceles, because of the location of the lesion. Now, one thing to remember is when you resect one of these lesions, there may be a requirement to perform superficial parotidectomy because of the location. In that case, you have to figure out the relationship of the lesion to the facial nerve, because it may result in facial palsy at the time of resection. The third and fourth branchial cleft cysts are lumped together. They're extremely rare. I'm putting them together because both tend to have fistulous tracts to the piriform sinus, and both tend to be intimately related to the thyroid. Now, the third branchial cleft cyst is usually in the posterior cervical space, posterior to the sternomastoid, but they can occasionally be in the lower neck close to the thyroid. And the differential for that would include thyroglossal duct cysts and laryngocele. Now, the fourth branchial cleft cysts are always on the left side for some unknown reason, and they tend to be in and around the upper left thyroid lobe. And again, the differential would include thyroglossal duct cysts, thymic cysts, because there can be remnant thymic tissue there, and thyroid lesions such as colloid cysts or abscess. And over here in this patient who is a 28-year-old, we have recurrent thyroid abscess in the left upper lobe. And that turned out to be third branchial cleft cyst. So to summarize, we have reviewed how to evaluate cystic head and neck lesions in children based on their clinical presentation, acute versus chronic, long-standing, recurrent infection, based on their imaging characteristics, and also on the location, which is the most important thing. Are they transspatial? Are they midline versus paramedian? Or what spaces do they involve? Thank you for your attention.